Dr. Sean G. Boynes is a dentist anesthesiologist who received his DMD from the University of Pittsburgh and completed a 3-year residency in anesthesiology from the University of Pittsburgh Medical Center in 2006. He currently serves as president of Dental Medical Consulting, where he builds success in business development and team engagement. Dr. Boynes produces data-driven insights, technology roadmaps, and creates and implements program design. He is an innovative strategist and a transformational healthcare leader. A prolific author and speaker, he has been recognized by many organizations for his work in health policy and clinical care. It is my pleasure to introduce you to Dr. Sean Boynes.
Thanks so much, Beth, and hello everyone out there in the webinar world. Thanks for having me, and look forward to being able to present information on the oral systemic links and health, the sharing approaches that we have from the dental, medical, and behavioral health side. Conflict of interest, I have no conflict of interest to report. You can see the objectives for this particular course here, and as well as on the website. So I thought a good place to start would be in the past, and decided to kind of think through this presentation in a way of talking about how we got to where we're at and sort of what the future of integrations will look like. So there's a lot of meanings of integration that are out there.
Dr. Boynes, I hate to interrupt you for just a moment, but there's a box on your slide. I don't know if it's on your end. There, it disappeared. Never mind.
Oh, okay. Yeah, I see it. It keeps coming back, but I have no idea
Still there.
what that is.
Well, we'll go ahead and we'll try to troubleshoot it from this end. But
Okay.
is it showed up on your computer? Is it on yours?
Yeah, it keeps coming and going away.
Okay.
So apologies for that. Hopefully it will disappear and stay that way. But at the end of the day, we have a lot of definitions on what integration is. Medical dental integration, there's over 100 of them actually that are out there. You can see some of the definitions that are in place, but it really speaks to the fact that this medical dental integration affects a wide range of individuals, both in the healthcare sector and those that are outside of it. And there's a desire to grasp and understand exactly what it is and how complex it ultimately becomes, which is why we have so many definitions, and it means different things to different folks. So the idea is there a right or a wrong thing to call this or to define it? And I think there are right and wrongs, but ultimately, when you start looking at all the organizations that have put definitions forward, you start looking at the type of providers or the type of individuals that are putting definitions and terms forward. They all make sense depending on what angle and what point of view you come from. And we'll kind of talk about how the research kind of helped define some of these pieces as we move forward. So the past is trying to figure out exactly what it is. The future is trying to figure out what it becomes. And I really think the future is going to be much more data-driven and data-informed than even where we're at today. And here was a great analysis that was done by McKinsey, sort of looking at the future of healthcare and really coming down to something called virtual experiencing, which is I'm going to have a lot more control of my health, not my healthcare, but my health. Healthcare is a portion of it, as you can see, but I'll have more control and understanding of my health through the data that I have that's beyond just what's happening in the healthcare sector. And so as you can see from McKinsey, they really identify sort of these 5 ranges of data that will help inform the person through their health, their financial data, their social structure data, there's patient-generated clinical data, there is the health and wellness data, your Fitbit, for example, and then provider-generated data. Up until this point, we've really lived most of our existence and integration around provider-generated data and financial data, trying to resolve those 2 pieces. As we move forward and more data becomes available, and we start to see big tech get more involved in oral health, we'll see better opportunities to be able to inform oral health and dental care beyond what's happening in the dental chair or even what the patient reports. There'll be real data coming in about habits and behaviors that we've never had before, all centralizing itself within sort of a centralized dashboard, a data set that each individual will have. And so we're somewhere in between figuring out what integration is and advancing into this virtual experiencing sort of platform. And what I plan to do today in the presentation is just kind of take you from the beginning into where we're at today and hopefully give you some futurist views on where things may be going to help solidify and advance medical dental integration from where it's at. So a way to do that is through a shared story shared with medicine, behavioral health, and dentistry, which is those that do not study history are doomed to repeat it. And so I thought I would take us as time travelers, and I put as many of the fancy time travelers as I could, trying to be generationally appropriate. So hopefully every age group that's on this webinar can relate to some time traveler they've been exposed to on TV or within the movies. But I think the idea is, can we go back and take a look at what got us here and help to better inform where the next steps may be? So back in the early 2000s, and there was some work that was done in the 90s. I think of the work like Bert Nettelstein did early on, really trying to push a lot of the caries as the most common childhood disease to a litany of other organizations that started really exploring what I'll say is the molecular or the microbiome structures within the oral cavity that started to connect a lot of the mouth back into the body. And so in early 2000, we had sort of these pieces that came out with systemic diseases caused by an oral infection. This is from Lee, which was kind of one of these early ones that tried to explain what the systemic links were. And in the paper, they really say there's three sort of processes that can connect what's happening in the mouth related to inflammation caused by bacteria to the rest of the body. And one was metastatic spread of infection from the oral cavity as a result of transient bacteremia, metastatic injury from the effects of circulating oral microbes or toxins, and then of course the metastatic inflammation caused by an immunological response. And so really a lot of the studies looking at what is delocalizing the infection or the inflammation that's occurring in the body, in the mouth, and resulting in a response in the body. Really starting to identify gram-negative anaerobic bacteria, understanding what they are beyond things like Streptococcus mutans, starting to look at both caries and periodontal disease, understanding if inflammation occurs, how does it affect the body, and what are those molecular microbiologic organisms that are causing a lot of the issues at hand. And really starting to develop that dysbiotic microbiome that can occur, that when you have this biofilm and these sort of bacterial products, it really results in a stimulation locally of things like the periodontal ligament and the gingival tissue, as well as the tooth tissue. And that ends up causing responses from the rest of the body in order to treat that inflammation. The other thing that really happened in the early 2000s, so we were looking at periodontal disease. We were trying to understand the inflammation, understanding how that was interacting with things like diabetes, cardiovascular disease, looking at stroke and the outcomes from that. And also starting to look at what can be done on a preventive aspect for children. We were becoming well aware in 2000, we had the Surgeon General's report, which really pushed out the idea that there's a silent epidemic going on in the United States, that caries is the most common chronic disease in children, and that dentists were more likely to see kids after the age of 4 or after the age of 5. And how can we get more coverage and have a better preventive platform? And that's what you see all the way on the right, which is sort of really pushing the physician's role in the integration structure. So we started having a lot of these research articles coming out really focusing on what are some of the causes that can make the mouth be a negative byproduct, if you will, of the rest of the body. And so it started to come into our consciousness. Just to get a little bit more detail, one of the main pieces was looking at the ecological plaque theory, which is that you would have sort of in your mouth already a non-karyogenic plaque. You have a microflora that gets adapted to a low sugar diet. You start adding these sugary acidic drinks, or you decrease the pH, you make it more acidic in the mouth. This causes these low pH episodes, which then causes some changes in the microbiome that's more negative, that can cause those karyogenic bacteria to proliferate and produce even more acids that can start to really tear down the structures and the tissues in the mouth, resulting in those acidogenic, acidic flora, and really producing karyogenic plaque in the mouth, which eventually takes the mouth from this beautiful white, straight, beautiful smile into something that looks more like this. And so we started to see a lot more of this information becoming more widespread, ending up into the attitudes and awareness of the providers, and sort of this understanding that, hey, between the ages of 0 and 4, 0 and 5, we have this microbiome that forms. And can we start to team up better with pediatricians and family practice physicians in order to get the interventions earlier in the system, so that over the long run, there'll be less of what you're seeing on your right and more of what you're seeing on the left? And can we start relying on the medical side of things to help with those interventions, considering that the medical side is going to see these individuals about 11 times more in those early age periods than dentists are. We started to understand a little bit more about caries disease and inflammation. This one analysis I'm showing you here is showing the primary teeth, these proximal carious lesions that extend more than 50% through the dentin, appear to have more extensive inflammatory pulpal changes. And so as we start to really understand inflammation in the mouth and its effect on the body, understanding that there's this localized response happening in the teeth, most likely related to these pulp horns that you see right here, if you're not familiar with where the pulp horns are, which contain the abundance of our nerves and tissues. And so if we have a type of cavity that forms on the tooth and it has easier access or an easier pathway to those pulp horns, it's going to produce more inflammation. And so we start to really want to think about how we can interact and intervene in this process to prevent the inflammation from happening from cavities. The other thing that was going on in a lot of the research is this understanding that there's a lot of issues within the periodontal disease, and we probably and do see more systemic inflammation from periodontal diseases and gum diseases than we necessarily do from cavities and caries activity. And so this particular slide really highlighting that dysbiotic microbiome that causes this delocalized inflammation response and results in what is really this systemic reaction that involves those cytokines and chemokines like that you've heard of before, and we'll talk about here in a little bit, those interleukins and tumor necrosis factors that get released into the rest of the body. So when we start to have research like that, and we start to see sort of there is proof that there is a connection and a correlation between what's happening in the mouth and what happens in the rest of the body. Then the next kind of process that came up to move integration forward was following the money. And so we started to see the benefit and insurance companies take a look at this, right? They're getting this other research that's saying, hey, it seems like if somebody has periodontal disease, there's increased inflammation and it's affecting their diabetes, it's affecting their heart disease, it affects stroke, it may affect dementia and Alzheimer's. And so with that, they kind of say, okay, well, let's start looking at the data we have and see if we can determine if there's money to be saved or money to be found or money to be made more appropriately. And so between, '06 and really up until 2015, we continued to see some of the larger insurance companies and even the smaller ones. I'm using insurance companies in a broad term, it could be benefits, really start to evaluate and try to understand if they can make money off of medical dental integration. And sure enough, when they started looking at their data and comparing their populations to those that did visit the dentist, or those that had an intervention, or those that were getting, good periodontal maintenance and treatment, it was pretty consistent across most of these reports that there was a reduction in cost, there was a reduction in physician visits, there was a reduction in hospital readmissions and overall cost. Once that sort of happened, I think the momentum shifted and became much more palpable, if you will, and the change levers started to press a little bit more quickly as this financial information came in. So, we started with kind of in the early 2000s and some work that came before that, truthfully, integration work can go back about 40 years. I'm looking at the most modern interpretation of medical integration and where we're at today. But really, when the money came in, this is when we started to see more investment, where philanthropy was getting more involved. You started to see more opportunities for research and more opportunities to be able to take some of these platforms forward. And that sort of led us, after a decade of sort of both of those type of research endeavors, then getting into how can we come up with a framework and structure that people can take and adapt and adopt within their own practices? And how do we have an education platform that provides a nice level of safety to the population so that we feel people are appropriately trained and there's structures in place that the proficiency and efficiency of the care is good enough quality that it's going to produce the best outcomes possible and kind of meet the desires of what you want out of sort of change in the system. And so in 2010, probably one of the biggest levers that we had was the Society of Teachers of Family Medicine developed the Smiles for Life platform. There were some releases in publications prior to this. I'm going with the 2010 platform just because that's when it came out online and probably had its biggest dissemination push. And so really what Smiles for Life program was an online series of webinars and instructional videos, instructional graphics, and publications that provided the educational information that a clinician out in the field would be able to learn from, be able to take that information and be able to move forward different oral health mechanisms on the primary care side. A lot of the initial push on getting people to do this and creating buy-in really set on the medical side, trying to get individuals to apply fluoride varnish to pediatric populations. We've advanced beyond that at this point, but that was sort of where the start was at. In 2014, another big push was when HRSA came out with the integration of oral health and primary care practice white paper, which really provided a lot of guidance for those individuals under the HRSA umbrella, like FQHCs and rural health clinics, really providing guidance that allowed for not only awareness to increase, but the ability to study what was happening in the FQHCs, look at those populations and really start to determine, can this work and is there a pathway forward? NOAA came out with a publication shortly after. There was a series of publications that really came out. You see NOAA's publication here, followed by the Qualis analysis, and then followed by the MoreCare platform. As you move from left to right, you kind of solidify frameworks of how to do this and advance into some where the problem areas are. For example, with the MoreCare program, really starting to look at the coordination of care and referrals and also interoperability, recognizing that that was sort of a pretty big wall and hurdle to get over in order to start connecting and truly integrating the care platforms. Around this time, with the mid 2010s, a lot of these particular frameworks and the way these structures were rolled out were using really quality improvement programs. Uh, most of them similar to the Breakthrough Series collaborative structure put forward by the Institute of Healthcare Improvement. However, there was a large amount of groups that were doing a lot of QA platforms to really help with change management, going into these practices and doing the PDSA cycles that you see in front of you to really test the change mechanisms that you wanted. And then also tying into some of the measurement that was needed. You saw the creation and the movement forward of the Dental Quality Alliance around this same time. I think it was around 2008, that the Dental Quality Alliance was really formulated and moved forward as a broad-based group to capture some of the measurement that will be necessary to start connecting dental and medicine together. And so it was really these rapid QI programs that also connected a lot of the oral health integration platform into the triple aim that was put forward by the Institute for Healthcare Improvement, which is to decrease the overall per capita cost, improve the outcomes of care, making people healthier, and of course, improving the satisfaction of care for the individual or the patient. And so a lot of these programs that move forward on integration were really tied into those three mechanisms of the triple aim. So as these QI programs continue to move forward, one of the big pieces that come up is you have to look at the care flows and how people are really adopting oral health into their practices. And so it becomes, well, who should be doing these things? And really, a lot of the structures on the dental side were tapped around this biofilm, right? Which is kind of this dense micro community where all those oral health microbiome pieces, those microorganisms and those cytokines and everything kind of lives together within this biofilm, which does allow for those organisms to encapsulate. Now, the thing is there's good and bad bacteria in the mouth, so you're always looking for a balance. Right? The fact that we started to focus on the biofilm as a structure, and with the information that was coming in from the quality improvement programs to test these new frameworks of integration, it was really focusing a lot on dental hygienists and then their counterparts on the other end, the nurses, as sort of who would lead a lot of these endeavors to integrate medicine and dentistry. And so a lot of the research that was coming out in that mid 2010s period really focused on hygienists and nurses. Now, since that time, we know that, for example, medical assistants probably are more formidable and can enact more change on the medical side. And of course, we're looking at expanded function dental assistants and direct access hygienists that are also driving a lot of the change. But really wanted to share sort of those early pieces and why still to this day, hygienists and nurses tend to be the main drivers of where integration can kind of pivot into a larger utilization and larger connection. This one study was looking at, you see in front of you, was looking at the feasibility of co-locating dental hygienists in the medical practices. So it was co-locating 5 registered dental hygienists. They ended up having dual function exam rooms where you could do medicine and dentistry. They did find that there was sustainability in the project, as 5 of the RDHs remained in practice about 2 years after. 4 remained after 5 years. At year 1, you had about a 27% of caregiver child dyads that returned for evaluation and were highly satisfied with the services that were in place. So showing that you can co-locate dental hygienists into a medical structure and be able to get good results. Another analysis looking at medical providers and dental hygienists in pediatric healthcare, looking at basic preventive services. What they were able to kind of mechanize and move forward was reducing some of the barriers, improving some of the oral health outcomes, and decreasing some of the disparities when dental hygienists were active within the medical teams. The other thing that comes up when we think about the hygienists, especially if we're thinking about biofilm, we're thinking about that inflammation, thinking about them as kind of being the paramount window into the dental office for the medical side, is how comfortable are they looking at medical screening? And what it ends up showing is that most of those individuals tend to be very supportive, at least in the surveys, of what they would be willing to do. Obviously, easier when it's just a simple screening, tend to get less willingness when we're looking at things like blood samples or data samples that need to be collected. Just on the other side as well, looking at nursing, there are plenty of research to find that when nurses intervene within oral health behaviors, there are the opportunities for them to improve toothbrushing frequency, the use of fluoride toothpaste, and getting help brushing by a caregiver or family member. So really, when a lot of those initial frameworks came into place, it was those two provider types that were really identified as a mechanism to drive a lot of the change forward. And so when we're talking about the WHO, it was coming up within those two groups. Just one more piece here, looking at integrating maternal and children's oral health with nursing, finding that there is a mechanism within the pregnant populations that this may be the best provider type nurses in order to make the changes significant, not only change within the structure of being pregnant until not being pregnant anymore, but also in making sure that you get a dental visit by the age of 1. So we looked at the kind of connections with inflammation. We looked at kind of frameworks that, the money says is possible for us to build a business model around. We found people that can be responsible and have some ownership, but there were still issues that were coming up within the process. A lot of it around care coordination and why that's important, and also how is that going to be accomplished and get done. So as a lot of these programs were moving forward and we sort of got into this 15-year mark, 15 to 20 year mark, trying to understand how money could be made on the dental side. There's kind of a developing understanding that if we can make somebody with diabetes a little bit healthier, decrease their A1C, or decrease the inflammation, that they probably get a little healthier, and that helps the medical side, who a lot of the times will benefit from making an individual healthier. On the dental side, it was a little bit of a tougher pool to find where you could find savings and thus money within the overall structure and system. And so an analysis kind of looking at the association between medical well-child visits and dental preventive visits found one that overall there wasn't a lot of this happening within the overall healthcare system. And still to this day, we're not seeing huge uptake. There's still a lot of work that needs to be done to get primary care providers, pediatricians to utilize oral health. But of those that were doing it, we were finding that they were more likely to have a dental home. They were more likely to get in and have a preventive visit. They were more likely to get their care done if they needed fillings, and more likely to have better longer term outcomes from the process. And so the other piece that I think really captured a lot of the money side of this was really the fact that when these individuals were being seen, they were getting in earlier. So if they were being seen on the medical side and had an oral health evaluation, they were actually getting in to see the dentist earlier. So earlier intervention was occurring. And there were studies that were coming out. Probably the most well-recognized was done out of Ohio State University, which found somewhere around the neighborhood of about $300 per member per year savings, and getting an individual in earlier to a dental office or to a dental home, and earlier being under the 4 or younger, really getting better outcomes. And so what this study showed is, hey, there's some skin on that if you can have an oral health encounter or an intervention during a well-child visit, that group tends to get in earlier, and there can be some cost savings that are in place. The issue was, how can we better coordinate between those medical dental offices to get the referrals in place and to communicate the establishment of a dental home? And I think we're still continuing to struggle with getting that completely accomplished. The other pieces around care coordination as we started to study, right? So we said, okay, hey, there's benefit if we can find somebody who's pre-diabetic or diabetic who's not diagnosed and into medical care. It saves money, improves the system, meets sort of that triple aim. The same thing's true on the dental side. If we can see them earlier, we can find disease earlier than we've found it before, there's obviously cost savings. So what are some of the things that are limiting our ability to coordinate that care effectively? And so there's a couple of studies that are out there, this being one out of the Journal of Rural Health, finding that primarily the business model has a lot to do with that, that if you're in an accountable care organization, which makes sense, right? You're most likely being paid to get people healthier. You're most likely being incentivized to coordinate care more effectively between disciplines. FQHCs, that also makes sense. They're more likely to be co-located, more likely to have the technology in place or even the IT support necessary to do it. And then private practice, although this was rural private practice, kind of came in third. And that should make sense because from a rural standpoint, you usually have to see everyone within your area in order to have your to have financial sustainability. And so those make sense from a business model standpoint. There was dependency on the satisfaction and ease of electronic health record use, really finding that the easier it is for their electronic health record to do things, to monitor things, to help with decision support, the more likely they are to integrate and coordinate care. And then no-show rate. If I'm referring to a place or receiving referrals from a site that has a no-show rate of 15% or less, I'm more likely to continue to engage, more likely to have success, more likely to establish that medical home. The other piece is sort of looking at the dependency overall of coordination from a medical to dental and dental to medical referral capability. Looking at this, once again, individuals who reported EHR use 2.4 times more likely to administer fluoride varnish and conduct those risk assessments. And when we look at the referral capability or ability to coordinate care, those that signified a dependable medical to dental referral system, 4.5 times more likely to administer fluoride, do a risk assessment, and do self-management goals. So the kind of interdependence on how well an EHR system is functioning, do I have dependable referral capability in place if I find that disease, and am I going to be supported by the patient for showing up and the other partner, the referral partner, and getting information back. So all of this kind of brings us to the point of, well, have we achieved enough of awareness? Is there enough comfortability with a population to have an expectation of this type of care? And the answer is no. We haven't really been able to get to the threshold. What you're looking at in front of you is the Google Books Ngram viewer. This thing is awesome to mess around with if you want. You can look at things like how when zombie first was utilized as a word in published literature and when it became more popular or less popular, for example. So what this Ngram does is take all of the corpora, or the words that are published in all the books that are listed in Google. And you can go back to the 1500s and see when words are used more or published more and when they're used less. They do include medical, dental, behavioral health textbooks, so you can kind of follow along. What you see on the left-hand side of those percentages, those are very small. If I were to put in something like Sherlock Holmes into this Ngram viewer, it would pretty much dwarf these other words that you're seeing because it's used so much more. But in the world we live in, or the world we live in some of the time, you can see how often a lot of these words are being utilized. And what's interesting here is you put in sort of those common phrases that sit around medical dental integration. You find that really medical dental integration, if you put this into the Ngram viewer, doesn't really pop up really at all. You can't even get much of a reading. It's so close to that x-axis. You can get a little bit of a spike if you put in integration of oral health or integration of dentistry. But I'm really showing this to say, look, there's a lot of words that we come up with to try to call something something to have a better understanding. And there's popularity that these words have that help to drive the changes that are necessary. And I think looking at the word usage allows us to kind of understand where we may be at in spreading awareness and also getting these to be adopted into day-to-day practice, getting that translation. I think what's interesting here is you see dental medicine as a phrase really starting to decrease as interprofessional practice is increasing. And then you see things like oral systemic as a phrase sort of rising along the same time and parallel with interprofessional practice, but then starting to fall off and decrease, not getting to the popularity of where interprofessional practice is. The other thing that's nice about this Ingram user is for oral health literacy. It really should allow us to understand what words are being used, and maybe we want to start using the words that are more popular because we can get more awareness, get more knowledge spread around what's in place. Google Trends is another popular place to go. So I wanted to include this. You can see, looking at kind of some of the same words that are in place, I included fluoride varnish and systemic health in this as well. But you can kind of see sort of a decrease in some of the older utilized words and then an increase in some of the things that we're also seeing on the Ingram user, specifically around interprofessional practice and a lot of those phrases that are pretty synonymous with a holistic or whole body health experience. And here seeing the same thing with Google Trends, which is search how many people were putting the word in for searches. You can see how they kind of go down and come up similar to where the Ingram viewer is located. So I went through this whole piece to kind of demonstrate what many of you may know, that it takes about 17 years from the time you get a bulk amount of research and information and being able to do something with that information and appropriately affect and effect a population with clinical intervention. And there's a few studies on this. 17 years tends to be where things are at. There are some who think dentistry lags behind even further, an additional 5 to 7 years. And I think there's good course you could follow where you may find agreement with that statement that if it's 17 years for the healthcare sector overall, it's probably 25 years for dentistry. I think that's true for some things, but also understand why individuals may want to follow that sort of methodology. At the end of the day, it does look like it's about 17 to 20 years from the time we get really good research and there's consensus and belief around what that research is saying to the time that we can get it into translation and actually at the patient level. So here's kind of a look at what this looks like. I really adopted a lot of the research that was done by Steve Reese at the University of Pittsburgh, looking at something called valleys of death when research comes out, that you have to go through sort of these 3 buckets and fill each one up appropriately before you can get to the next. And at any given time between buckets, like as the water's pouring out, the research could be stalled, it could be stopped, or there could be some issues with it. And really, the process that is followed with translational science is you kind of start with the biomedical and human services research. You're looking for science information, ways to affect policies. If you think those are the early studies from the 2000s that we looked at, that's really started to look at a molecular connection between systemic health and some of the things happening with oral disorders and diseases. You then get into this clinical science and knowledge of, can we get buy-in and can we get the knowledge in the clinic side and what does that look like? Those are a lot of those publications and frameworks that came out in the mid 2010s that allowed for clinical knowledge to be spread. And really where I believe we're sitting right now is kind of getting into clinical practice and health decision-making, developing reimbursement structures, developing pathways that allow for wider spread of what was found in the early 2000s. So if you do the math and you kind of take a look at, depending on when you define those first pieces of research coming out for this modern era of integration, it puts us about a year or two behind this 17-year window. And so a lot of the things and changes that I think we're experiencing relate to the fact that integration has matured to the point where we're at this translational period. And it'll be interesting to see how we're able to move that forward, or if it goes through what is called that valley of death and doesn't necessarily translate all the way into practice. So with that said, now what? So I kind of went back, I said, here's the process, took you through that 17-year translational science journey that we went on with those three buckets. And now what? So we're somewhere between yesterday and tomorrow. What do things look like? And what is the future of integration and what's going to drive it forward? So we do have this shared need within healthcare to become more integrated and become more transparent and make it easier to move from one area to the next and have that inform the overall health structure of an individual. And so there is a need to move out of a fragmented provider network, which we're still in, into a more clinically integrated provider network, which we're seeing pop up and develop every day. There are these things that will enable that, which you can see in the middle of the slide, and we talked about in some of the previous discussion that we've had, but really trying to drive towards this more integrated platform. And in order to do that, we are going to need workforce. And so I think it behooves me to kind of just take a moment and say, we do have a workforce crisis going on across all of healthcare. It also is negatively affecting dentistry. You can see here some of those infographics and newspaper articles and news articles that kind of have come up over the last couple of months, really demonstrating that there's a backlog to get patients in most states, and that we're seeing a decrease in workforce coming out of the COVID-19 pandemic. Looks like we're being disproportionately affected with dental hygienists and dental assistants, but I would not necessarily sleep on the decrease in dentist workforce we're seeing, especially in the rural environment, where some rural counties are seeing as much as a 30 and 40% reduction in dental providers. And so in order to make change and to ask individuals to change, there have to be people there that can do it and that are willing to do it. And so I think it's really important for us to consider where workforce is at, how many people are available, and how does this affect some of those earlier frameworks that came out? Do they need adjusted to allow for the variability in practices where we're seeing hygiene appointments get decreased from where it used to be an hour to 40 minutes for adults, and where you used to have 45 minutes or even 30 minutes down to 20 to 25 minutes for a scheduled appointment for those examination and evaluation appointments. I think that's very important for us as a profession to continue to look at, especially as we continue to ask more and more within these visits. It's becoming very similar to what was happening in primary care and is happening in primary care, where you have all of these recommendations that you need to go through and you need to provide within a very short amount of time, where it's impossible to put every recommendation in place. And so you really need to provide comfort in some area of expertise and knowledge that allows a provider on the other end to not feel pressured to do everything that's recommended, but what's in the best interest of the patient, because the timeframes are getting consolidated down because the workforce isn't necessarily there to maintain the same level that was prior. And we want to be careful to not cause burnout. For the first time in recorded history, according to the article you see on the right-hand side, we're really seeing where doctors and dentists are part of this evaluation, behavioral health therapists, as well as things like podiatrists and optometrists, are really not wanting their children to go into healthcare. And I think that's a really big litmus test of just where burnout's at and where the future of healthcare is oriented. There's a lot to be said about this particular article and the science that comes out around this particular study and some that have happened since then, on just where burnout's at and just where people are feeling about what the healthcare system is now and what it's about. So, wanted to kind of have my public service announcement around workforce, because I am, my opinion is I'm very concerned about really making sure that we're setting up integration in a way moving forward that can be adopted and adapted in a way that doesn't put additional pressure on a workforce that's already burnt out and feeling a lot. So what I wanted to do is kind of just go through the patient journey on integration and sort of talk about some of those new pieces that may be out there to help with the hurdles and the small walls that are still standing in the way to be able to fully realize integration. And I'm developed it in the next part of this presentation of these three processes. One, business and clinical management, which you're think about the patients getting ready to come in for a dental visit. You have the middle portion, which is diagnostic, health building, treatment planning, and decision making, and therapy, which is sort of the patient is available to you to do an intervention and to have some meaningful structure to change behavior. And then the last piece is patient engagement, which is the other thousands of hours that the patient is not sitting in a dental chair or not really directly engaging with you. So kind of walk you through this structure. Wanted to come back to this slide because I think it's really, really important. And I think it's really captured what I think the future of healthcare is going to get to, which is you basically have your phone with all of your data on it. You can customize this data how you want, and you'll have a primary care provider and a team. You have artificial intelligence and health bots, BOTS, those nice chat robots that are out there that will help engage you and kind of move you forward what you want to design out of your health. And your health system and your healthcare will be one part of that. And I also think it's important because one thing we have to think through is how are we going to tie our data into the rest of this data and vice versa? How can I get data that's going to help decision making on my end to help improve the health of this patient? And so one way that becomes important is really making sure the front office is there, not just to be reception anymore and to schedule appointments and deal with complaints, but also to become somewhat of a navigator and to have knowledge around data. And so in order to do that, some of the time has to be freed up on how they're spending what they do day to day. They spend a great deal of time scheduling, calling patients, dealing with complaints. Is there a way to automate some of this process so that those individuals in the front office can help with the integration efforts that need to be in place, communicating with other providers, getting data and information in a way that can be easily sent to and read through by the providers who are working in the clinic? And so a couple of things to think about that are helpful in freeing up the front office to help with integration efforts is appointment and schedule management, making sure no-show rates are the lowest you possibly can. There is research out there that shows electronic appointment reminders do work. There's also research that shows, there's some research that shows one type of method, email, text, calls are better, but most research shows that there's no difference. Especially if you just ask the patient how they want to be informed. Would you like a text message, an email, a phone call? Would you like to just set it up in your calendar? If you can find the patient preference, it does seem to positively impact show rates. And one way that you can do that is then to automate that and outsource it to another company or vendor with those preferences to alleviate some of the time that you may be spending on it that can be spent better elsewhere. Intake's important. Paperless intake process saves about $12,000 per year. The research tends to find about 85% of study patients chose to complete those assessments via an electronic mode. That helps to free up some of the time when they do come to the office, or if you're doing some sort of triage with telehealth or teledentistry, having these intake forms up beforehand and getting sort of those problem lists that these vendors can provide to you saves a lot of time and obviously money. Referral management becomes important. If you're going to start dealing with referrals from the medical side, having a good integrated system is important. There are matching software programs that are out there now that can really be utilized effectively to engage not only dental to dental specialists, but dental and medical. Most of the online platforms, especially those that are free, really are tied into some of the pediatricians. We haven't seen a full range of interconnectivity just yet, but I have to tell you, I'm excited from the fact that you can now go on and sign up for different types of referral systems that are HIPAA compliant. And then last is interoffice communication, seeing a lot of investment in this, which is utilizing either an individual's phone or iWatch or instant messaging system on the computer in EHR that comes up that allows for better communication between what's happening at the front office, what may be happening at the back office, and then what's happening for the clinicians. That usually makes for a better person experience and also allows for the individuals to focus on some of those integration efforts. If somebody has diabetes, are you focusing on the things that are necessary for them? Here's a complete menu if you were curious of all the things that you can actually outsource that would help to free up time to do more integration efforts out of your front office. This particular portion, if you were to do all of these, there are vendors that are out there that can do this for anywhere between $250 if you want those basic level structures to as high as $1,000 a month. On average, you're looking at about $300, $350 per month to outsource all of these pieces. And obviously, if you work with a vendor, you can make a lot of the messaging that's in here very whole body or medical dental integration oriented, which starts to allow to bring your patient into the experience. If you think about all of the research I've shown you thus far, almost all of it's really been to get a provider, a dentist, dental hygienist, dental assistant, a physician, a nurse, advanced level a nurse to medical assistant, to get those individuals to be able to adapt and adopt in oral health. What this is starting to do is bring that front office in and back office in to the same process, which should allow for better patient communication on this integration effort, which would allow individual clinics or individual sites to sort of stand out from other dental services or dental businesses that may be part of a competition in a particular service area. The biggest drag to all of this is interoperability, which we're still struggling with. The good news is 2021, the ADA was with a good list of partners. One that I know was Miss Rebecca Feen, who was doing a lot of the driving of moving the oral health standards forward. So prior to 2021, there was no data standards or codes that could be passed through electronic health record systems. Glad that the ADA and other organizations were able to drive that forward. So we have those now. However, we're still struggling with getting systems set up to be able to utilize these standards and pass the information back and forth from one another. So just looking at some research, and I provided some sites you can go to. This is a really interesting piece. If you do have time, I would suggest watching the YouTube video that's up there. It's really interesting, concise, takes about 10 minutes. But talking about interoperability, the goal around it is to improve the coordination of care between business and care models. We see slow participation with dental care sites in these HL7 data exchange standards I talked about. And some of that is around the mixed payer environment. A lot more support and opportunity is going to be on the medical assistance side with Medicaid and Medicare, less on the commercial side. So that'll be interesting to see how slow or how fast uptake may be because of that. We do know the American Hospital Association is in favor of it, feel it's going to decrease costs, improve safety, but not every city buys in, not every provider and not every health system buys in equally. And so a big portion of how successful any site or organization or dental office is going to be with integration is in how interoperable their platform and their city and location is going to be. If you're located in Cleveland, where this recent study found it's 78% interoperable, meaning that the health systems that are there, the providers that are there, are sharing information with at least another data system or electronic health record system, you're going to have more success in Cleveland, which is 78%, than you are in Philadelphia, which is at 35%. So the overall city average is around 42% interoperability, which is still too low. A lot of the experts really say you need to be above 70% in order for there to be multidisciplinary, interdisciplinary exchanges to occur. And so we still have a lot of work to move forward. It also could set up a haves and have nots kind of system, right? If you're located in an area that has more interoperability, you're probably going to be able to do medical dental integration, take more of those patients in. And if you have the money to invest in technology, you have the money to invest in this process, you're probably going to be able to get a bigger market share and move forward faster than those that do not. And you may find yourself even in a situation where it's not relevant or even something you want to invest in. And so I think when we talk about the success at the downstream level of medical integration, interoperability becomes unbelievably paramount. And I've yet to see an oral health organization, a coalition, or an expert body really set their sights on interoperability from a dental standpoint and really invest and drive to make a measurable change in the amount of interoperability in a city, a state, or a region. And I think until that happens, it's going to be very difficult, I think, for a dental business to take on the risk that's associated with integration and payment reform, especially if, say, you're in Philadelphia and you only have 35% interoperability. Really sets up, it's going to be difficult to communicate between medical and dental. The other thing that should be concerning for us right now to have integration move forward is that not only are we seeing the percentage of interoperability not where we need it, we're starting to see entities pull out of wanting to be interoperable, pull out of health information exchanges, pull out of opening up windows into an HL7. And a lot of that's around the proprietariness of data and those insights. If you're, for example, a MRI business, and that's what you do is you do imaging to make money, the more interoperable you are within that system, the more that particular system could just take your imaging and put it into their system and operate it that way, or could just exclude you from the system, right? To say, well, we don't really accept images from there because they're not interoperable. And so we're starting to see where fragmentation is occurring around interoperability, where you have one health system on one type of electronic health record, only accepting images that may be coming into there. And so it does set up for a dynamic that we need to keep an eye on. We did see 500 plus multiple specialty practices also stop giving access into hospitals, providing that data and what those hospitals may be doing to make money off of that data, and not necessarily setting up good data sharing agreements, also becoming problematic and interfering with integration. So there are these sort of big pieces that need to have large bites taken out of them that we're still struggling with, is slowing this process. And it is that patient data is leverage and who owns the data. We see a lot of private equity and venture capital coming into oral health. How much do they own the data? How much does the patient own the data? And then what are the ethics? And we still haven't resolved a lot of those pieces. And I think until we do get into full-blown integrated platforms is going to be difficult. All right, so we talked a little bit about the things we need to do on the front end when patients are coming in. So, the business management and the patient management structure. I want to talk a little bit about getting into the treatment areas with integration and kind of where medical dental integration sits now. So we talked a little bit about this early on. We've kind of developed it and evolved it since those early studies in the late 90s and early 2000s. We've really brought in diet and nutrition and the dysfunctional mastication system as this pronounced area. We see a lot of initiatives around this, whether it's food as medicine or healthy food, healthy teeth, and a couple of other programs and initiatives that are out there. Symbiosis and dysbiosis kind of replaced that bacteremia and toxins floating in the bloodstream. We kind of understand that there's a balance that we want. It's not getting rid of all the bad bacteria. It's creating a good balance between good and bad bacteria. And then inflammation continues to be the main enemy, the cry that goes out to bring everyone to fight. Everyone within this integration platform, their main common enemy is inflammation. It's those things that cause inflammation and those sort of processes that come in place that causes that body to respond in that negative way. What we've been able to do is advance our understanding of those microorganisms and those microbiological and molecular mediators that occur to allow us to get a more well-refined understanding of what's occurring. And so you see here, this is really one figure of many. I chose this figure just complete candor. It has a Creative Commons license, so I can grab it and quickly get it on a slide, and I'm able to provide it. But please Google inflammation and bacterial mediators and whole body health, and you can get these sort of beautiful figures that sit up that really signify we're starting to understand, and we can start to isolate some of the oral bacteria that have implications in some of the systemic diseases. And we can do that. We can also start to understand what are those inflammatory mediators that share a pathogenesis in the oral cavity and which ones are systemic. And those are these C-reactive proteins and interleukins and prostaglandins and the famous polymorphonuclear neutrophils, which we know kind of are the first phase of signaling over to the rest of the body that there's some problem going on in the mouth that can no longer be resolved with just the microorganisms that are right there in the mouth. And we need a whole body response in order to address the chronic disease that's going on now. And so we're getting more refined and we're getting more knowledge around these mediators in this bacteria. And so when we think about the future of how integration can occur, in my and others' opinion, it really does come down to this molecular strategy, that if we can start to think and shrink ourselves down into that little figurative submarine that allows you to go into the body, where we can all come together, medical, dental, behavioral health sits around a lot of these inflammatory mediators, a lot of these microbiological pieces that are part of our body, and all these single cell organisms that decided to come together around the frequency that is us as a human being, and start to make real interventions and connections beyond putting fluoride varnish on a tooth or screening for diabetes, but really making change because we're starting to balance the things that are causing the physiological response. That is really what we're trying to fight. And so we have salivary diagnostics is really that first great step forward. And this is something you can do today. You can get a salivary diagnostic kit right now for anywhere between $90 and $150. We are limited on where reimbursement is at, but saying these things are possible today to do. And I think it's important. This is giving you, a real readout of one of the salivary diagnostic companies and tools where they can compare how you stack up to rating with karyogenic bacteria, to where your periodontal disease may be at, to probably more important to the individual, even what bacteria you may have that's causing bad breath or halitosis, and how to effectively treat that. And the other thing that's really interesting is the artificial intelligence that's sitting on a lot of these platforms. And you see that at the bottom of the screen here, which is looking at making recommendations of what products and agents may be best for you to utilize in order to offset the bacteria that you're seeing. And so you would have a treatment mechanism where these salivary diagnostics come in. You get this readout of where your risk is at, and you can start to share those risks in that bacteria, not only with the patient, but also broadly as an integration effort as you move forward. And there are real world consequences to being able to do that. We still sit in the mechanical age. This was a study that came out from Bristol, who's one of those salivary diagnostic companies. Forsyth is another company that also does that, and there's several that are popping up, including this particular research publication, because I found it interesting, right? They kind of looked at what's affecting the microbiome instead of did you brush your teeth twice a day and did you floss, but really getting into, okay, how effective are you at brushing? And while this particular analysis found that electric toothbrushes are better than mechanical, I'm sure there are some individuals that did better with mechanical brush. And so we're getting into that personalized structure that allows us to maybe more positively affect the microbiome and thus health, and thus systemic health overall. I think what will probably be the next transformative step is as we get more and more research through these diagnostics and we start to understand how these individual microbiologics are being affected and what's making people healthier and happier, then we can start looking into what agents are effective to start positively signaling to the bacteria the way we want them to, and thus having more control over these the things in the bacteria that sit in the microbiome, and that will have agents and products that will allow us to enact a healthier change in the mouth beyond the mechanical pieces of scrubbing or removing biofilms, but really getting into chemical signals that allow us to either break up biofilms earlier or get the bacteria to act the way we would like them to. That all kind of leads into risk, which is a big portion of what we need to do from an integrated platform. The idea is that we move from finding disease, stopping disease, and hoping it doesn't come back, to how do we more effectively prevent disease and provide those protective risk factors that are in place, while also better identifying for the population. I think the big issue that we have to overcome right now is most of our risk stratification sits in three realms, either low, moderate, or high. There are pushes from different organizations and entities to add a extremely high risk or to add a rising risk. So you're either looking at intervening more effectively within our risk stratification at the low to moderate risk, so understanding the population that may be rising up from low risk, or the other school of thought is we have really frequent flyers that cost a lot of money that sit at that very high range. Can we break that population out? I think at the end of the day, really what we need to drive to make integration work from a financial standpoint, especially if value-based care and alternative payment models are going to be a main mechanism to make integration work, is we need to look into getting into a 4-tiered system, similar to where medicine is at. For a main reason that we would line up better with medicine, as you see here on the right-hand side, but also that we're starting to line up better with the financial and the money aspects of the business of dentistry, which you see here. A lot of those risk stratification pyramids that you see, especially on medicine, are tied into finance and getting predictability on how much an individual may cost. And so if you can do that, then you can probably tie into medicine more effectively. Here, I'm just sharing a typical 401k financial pyramid, but it should make sense how we're lining people up for money, right? Our low risk are going to be those savings and T-bills. Those are individuals that aren't going to cost the system more money. They're going to be more integrated into the system and probably allow us to focus on the other individuals more if we set our system up right. And the top is your speculative, right? Those are individuals that are more unhealthy and cost the system more money. But if you take a risk and make them healthier in an integrated system, you're probably going to be able to make more money off of those speculative if you can make them healthier. At the end of the day, however you set up your business model, the idea is our risk stratification has to overlay with the financial model in place. Most of the financial models that actuarials use, or even just the business individuals in this sector, they really do look at it on the pyramid that I'm seeing in front of you, and the way that individuals are doing risk assessment really overlays well with the financial risk, not just the health risk of the patient. All of that leads into better artificial intelligence, being able to get patients quicker and easier. We're going to need to be able to do that if we're going to integrate the platforms. One thing that may make life easier are artificial intelligence, like what you see in front of you. I know there's a lot of platforms and programs that are out there now. A lot of them are able to go in, look at a radiograph, read the demineralization that's sitting within the tooth structure. And as you can see on the right-hand side of this picture, which is an actual platform, develop a treatment plan that may be best based off of the radiologic survey that's in place. There's accuracy as high as 99% on this, as low as 73%. So it could assist dentists and radiologists to perform a better and faster examination. And so this is something I think will make life a little bit easier to find those earlier lesions that may make prevention more sound and more economical. the idea would be, as you can see in front of you here, you would reduce the amount of pediatric restorations, for example, that would occur. This would save money to the system. You would utilize your pediatricians to find these things earlier, get people in to the office earlier for an evaluation, and hopefully eliminate that watch to be able to effectively save money. So what does all that mean? It really means we're looking at dichotomizing the approach, where we separate the classification and how we're going to provide care. What is an unknown system right now is what is the right co-location. If we're going to separate out dentistry into a primary and secondary intervention, which is, how do we do earlier evaluations to prevent disease from forming, or if the disease is in its earlier stages, which you see sort of to the left of that dotted line, what's the best way to provide that care? Is it dental hygienists being embedded on the medical side so that they can do secondary intervention if through the primary care process this is found? Or is it to keep co-location the way it is with a full dental hygienist, dental assistant, dentist team with their front office, because there could be more disease like what's seen on the right-hand side that needs to be taken care of more effectively? I don't think we know, and I don't think that research is in place to really determine where is co-location and what's involved with an integrated team. So we'll have to kind of develop that and see as we move forward. I think a lot of the platforms, especially through value-based care, is when you look to the left of that dotted line, is to really move that co-location in with primary care. And so you would have a full primary care scope, which would incorporate the dental aspects. I think what CMS's guidance on Medicare, looking at medical necessary dental care because of your condition, really sets up to move primary and secondary closer to primary and secondary interventions. So evaluations, fluoride varnishes, silver diamine, fluoride, remineralization agents more in the primary care side, and move that tertiary care pieces where dentists may be able to do more of those surgical interventions. I think that's what the value-based care platforms are seeing. Don't know how this is all going to mesh itself out, truthfully, but that's kind of where I'm seeing the divide point come in. So that's where the therapy sits. So started with sort of how we're going to engage, how we need to free up the front office to be able to become more navigators and directors in healthcare for the patients. We talked about how therapies are changing into more salivary diagnostics, which to me is the real integration. When we can get at the level of the microorganism and the inflammatory mediators, that's where we're really going to find the outcomes that we still have not driven towards yet. And so lastly, how are we going to engage and keep people informed to the process and keep them wanting to think about oral health more than they do right now? And a lot of that's through engaging in relationships with patients, providers, and using technology as the medium. What's old is new again. So this is Hippocrates saying it's more important to know what sort of person has a disease than what sort of disease a person has. This is going way back into the initial founding days of modern medicine. So you can see we're still trying to get to that point of being able to find the person in the midst of the disease. And a lot of that's going to be carried on personalized care, which is going to take these data-informed processes, make them more predictable, utilizing the data that we have in order to promote health and prevent disease. And the big driving point around having this data and being able to engage around an online medium is to make an impact out of the 2 hours that the individual is really seen on the dental side, and maybe the additional 1 to 2 hours seen on the medical side. Just taking a quick check with me, the billing is personal. What these what these 2 slides point out is there's more mechanisms to get reimbursement on the medical side. So if you're medical doing oral health, it's a lot easier than it would be on the dental side doing primary care. As you can see here, while we have codes that have moved forward effectively, and now those codes exist that we can use, the reimbursement for those codes, or even insurance companies taking those codes without denying an entire claim, is still very limited. And so we'll need to get through that, because when billing becomes part of the process. And if a claim gets denied or a person is expected to pay out of pocket for this type of procedure, the chances of that happening or the chances of an individual site incorporating it is fairly slim. And I'm sad to say we're still a far way away from consensus in making a uniform structure for reimbursement, either primary care on the dental side or dental on the medical side. A lot of this sits around care enablement and what we're doing. This is much more popular on the medical side, and so it does make for an issue. I would certainly like to see more philanthropy funding in dentistry around trying to engage more effectively around enablement. I think medicine is a little bit further ahead than where dentistry is at. And so it would be nice to see new collaboratives, new programs that are being funded that will allow this care enablement piece to be figured out better. Right now, it's definitely more of a square peg in a round hole of how to design the structure between what happens on the dental side, what happens on the medical side, and how we're engaging and interacting with individuals, where oral health fits in that process. There's a value to the data that we have not figured out. That's part of this engagement process. That analysis from, there's an analysis from Rolange Berger, which found that of the 500 industry insiders that they talked to, they think that there'll be different players that will own different types of customers, whatever those may be. There'll be different customers that move to different platforms. Think of the difference between Uber and DoorDash, or Uber and Lyft and Zip. There's sort of preferences that people have to be really, as you see in this last bullet point, from the customer experience, not necessarily the health benefits of the platform that's being used. And the other thing to keep in mind is that the tech companies are going to have an edge in prevention. If you think about it, Facebook has a lot more information on behavior and what the individual is doing in their day-to-day that more likely will affect prevention than the information that's coming from a provider electronic health record. What they found is that basically there's more trust if you have a chronic disease to your provider and you trust them with your data. If you're not sick, you're more likely to let the tech companies inform the process. So that leads to online engagement, which is how are you going to engage? Your website is more important now than ever. You need an application more now than ever, and you need to have some sort of presence on social media now more than ever. You're trying to improve the engagement and get people to look at your social media, to get on your webpage outside of the 2 months that they may have been at your office or moving into coming to see you at your office. A lot of that leads into making sure you have dental home status, net promoter scores are effective, that people are recommending you, and you're getting feedback online. In order for integration to be effective on the dental side, this online integration platform is important. There is linkage between what they're buying in from what you're saying from an integration standpoint and how much willingness a patient's going to have to be in an integrated structure. A lot of this can be moved forward with smart engagement, thinking about how smart toothbrushes can help inform this process around as a litany of other things like Fitbits and the salivary diagnostics that I told you about. Are they using those agents or using those products? With that said, I know we reached the end. I'm sorry about this little box that was up there. Hopefully it didn't interfere with the process too much.
Well, very good. Well, Dr. Boynes, thank you so much for your time today. We really appreciate this extremely informative presentation. You never let me down. I always learn something new, and I love the data that you share.